Good morning, everyone. Now we have seen about deviated nasal septum, uh, which we thought may be a disease or maybe an anomaly. But now we'll be dealing with the diseases specific to the septum. With respect to my teachers, we will begin today's class. The diseases which we encounter here are the fractures of the septum, septal hematoma, septal abscess, and septal perforations. What are the septal fractures? Septal fractures are the fractures which occur on the cartilage or bony part of the nasal septum. They are seldom isolated, that is, we don't expect that only the cartilaginous septum or the bony septum will be affected. It is most of the times secondary to a facial trauma, which can be a road traffic accident or a fall or a injury either by voluntary or involuntary action. So most commonly what we have is a septal fracture. Normally whenever we see that there is a septal fracture or a nasal fracture, what we mean is there is a fracture of the septum as well as the nasal bone. This will be called as a nasal bone fracture. Supposing the nasal bone is associated with fracture of the facial bones, that is the zygoma or the orbital or the frontal, that is what will be taken as a leaf-foot fracture. There are three different varieties of leaf-foot fracture which we'll see later on, and majority of the times the leaf-foot fracture is associated with head injury because essentially the kind of the severity of the trauma for a leaf-foot fracture will usually be associated with a head injury also. So depending on this, we have different varieties of fracture. For septal bone fracture, what we have is there are two varieties of fracture. One is a Jarjavis and the second one is the Chevalier fracture. What is the difference? The Jarjavis fracture is because of a lateral injury to the nose, whereas septal cartilage is because of the Chevalier's fracture is because of the frontal injury. What is the difference? One is a vertical fracture which extends along the Cottel's line. I hope you remember what is Cottel's line. While the Jarjavis is along the vomer. If you can remember, the septal cartilage is situated on the vomer bone between the equatorial perpendicular plate. So the Jarjavis will always be parallel to the vomer. So this is what the fracture of the septal cartilage would be. But at the same time, they are also associated with nasal bone fractures. Supposing instead of all this, we have the facial bone fractures, which have been divided into Leafort 1, Leafort 2, and Leafort 3. Leafort 1 is only and only the maxillary, the alveolar process of the maxilla has been separated from the other part of the maxillary bone. That is, if you are the patient is in the casualty and you are able to move the incisors with your hand and there is a movement of the maxilla without the movement of the head, that means this is what is a Leafort 1. What does the Leafort 2 implicate? Leafort 2 implicates there is a fracture of entire maxilla with the involvement of the orbits also. This spares the zygomatic bone. But supposing if the fracture severity is so bad that there is a craniofacial dissociation, that is, the cranium is separated from the facial bones. That is what is called as a Lefort 3. This will result in what are called as a typical raccoon eyes. Raccoon is a mammal for which it has got something like the panda. Dark, the eyes are periorbital blackening or darkening is there. Those are what are called as a raccoon eyes. This is what is the hallmark of Lefort fracture. So what do we do in this? For all, for all fractures, the treatment is reduction. Majority of the times, the reduction is a closed reduction. Very rarely, unless and until we have something like a Lefort fracture or complex fractures such as the orbital-ethmoid complex fractures, we normally don't do an open reduction. The open reduction is done by a maxillofacial surgeon. So all this thing fractures are invariably, if they are associated with the point of break or the point of fracture is in the level of a point at which the blood vessel is crossing the cartilage. This will lead to a septal hematoma. That is, as per the severity of the disease, we have either a small injury which will lead to a small localized hematoma, or as the severity progresses, it may go on to become a large hematoma, which may be unilateral, may be bilateral, and there may be a fracture of the septum. This fracture may be again dependent on the severity of the trauma, be isolated septal cartilage fracture or septal cartilage and nasal bone fracture, or nasal bone fracture with or without facial fracture, or if the severity is really bad, then we may also have a head injury with a facial fractures. So the severity of the trauma will determine whether you are going to have a simple hematoma or a simple septal cartilage fracture or a nasal bone fracture. So people, especially in small children, they have this habit of rubbing the nose or finger picking. What happens there? We have an injury. Now, this will lead to a swelling, accumulation of blood between the perichondrial plane and the cartilage. Please remember, cartilage as such does not have a blood supply of its own. Bone has got a blood supply of its own. Bone doesn't have a nerve supply, but cartilage depends on diffusion from the capillaries for receiving the oxygen. So now what happens here? We have a blood accumulation between the perichondrium and the cartilage. Unilateral is in a way better, but it is normally not found. What happens whenever there is a fracture or there is a blunt injury? There will be a tear. The tear will lead to a tear within the perichondrium. The blood will separate the perichondrium from the cartilage, usually seen on both sides. Now, the cartilage is not receiving oxygen. What will happen? It will lead to necrosis. That's why septal hematoma is considered as one of the emergencies as early as possible. The more delay, the chances of this forming necrosis of cartilage, and further sequelae will increase and will lead to definite supratip depression. How do we see this? The clinical features include first the nasal block, because the block is at the level of the nostrils, so which can be seen on anterior rhinoscopy as uniform bosselated swelling. These swellings are blanching on touch. They are compressible, but they are not reducible. I hope you understand the difference between them. If not, please go through the ESDAS, clinical methods in ESDAS. So we have a uniform bosselated swelling which has to be drained. Something like a Freas incision. We give incision on one side or both sides, suck out all the hematoma, and do anterior nasal packing. Anterior nasal packing has already been described to you, so I hope you people remember. You people are also supposed to remember what are the substances or the various uh, ointments or the procedures what we do for paste that is required for doing the anterior nasal packing. And please remember, because this is a hematoma, we cannot allow it to organize. There is no medical treatment. There is only and only a surgical treatment, that is incision and evacuation of the hematoma. But because we remember all hematomas, what are the sequelae? What do you mean by sequelae? Sequelae are if we leave any condition for its natural progression of the disease. What will it lead to? The most common would be the supratip depression. Why? Because there is a loss of cartilage along the site of hematoma. So this will lead to a supratip. Why supratip? Because the alar cartilage are completely different, which is at the tip. The dorsum, bridge of the nose, is by the nasal bones, which again has got a blood supply. But the middle part, which has got the septum, the dorsum of the nose is made up of the septum. This will be necrosed. That's why there will be a supratip depression. And please remember, oral cavity and the nasal cavity are one of the most contaminated places in the body. That's why formation of an abscess is actually a rule. Very few times we come across that there is only an hematoma and there is not an abscess. But now the very rare or unlikely that we see a perforation as a sequelae. Why? Because we don't wait for the, because of the easy availability of the doctors or easy availability of the treatment care, or there is awareness, people don't wait for any other reason. Previously there was paucity of the doctors and coming and going, the travel options were very less. That's why they used to have hematoma which would lead to depression or the necrosis of the cartilage. At the same time, the mucosal pericontinental layer will also be necrosed. That's why there would be a perforation. So now we don't see perforation so often as we see an abscess. We don't see supratip depression as often as we see an abscess. So this is what is a hematoma. What a septal abscess? Usually these are all secondary to infection in a hematoma. Why is it a hematoma? Because the nasal cavity is full of all saprophytic commensals. So what will they do? They will have opportunistic reaction with this. So the moment we have hematoma, that's a very good agar, blood agar. So we know all the infection will thrive in any hematomas. That's why we have an abscess. The question then comes, how do we differentiate it from a hematoma? Please remember, we are having abscess, that is, there is pus. The moment there is pus, the cardinal signs are fever with chills and rigors. That is why the moment we have a child who is brought to us with a nasal obstruction, who is showing on both sides, uh, there is uniform bossulated swelling, and he does not have history of fever, that means that is only a hematoma. But if he is having a uniform swelling with there is fever with chills and rigors, that means we are having a septal abscess. Again, what is the treatment? Surgical treatment is the only option. Please remember, abscess doesn't have any medical line of treatment. That is, we have to do incision and drainage. That is, adequate incision and proper evacuation of all the loculi. At the same time, we are also supposed to maintain the cartilaginous integrity. We need to make sure whether there is any necrosis or not. So there is surgical treatment of the abscess. Next comes the perforation. Septal perforations are either because of congenital causes, inflammatory causes, infective causes, traumatic or malignant, of which inflammatory and traumatic causes are the most common, and that is why we will be dealing with those cases. Inflammatory causes, acute infections normally would not lead to any perforation, but say the tuberculosis, specific chronic specific inflammation, that is tuberculosis, syphilis and leprosy, they will cause septal perforation. Tuberculosis will be anywhere in the nasal cavity, nostrils. Syphilis is known for any perforation in the bony part of the septum. Leprosy again on the skin and the hair bearing area. Apart from all this, there is also what are called as specific granulomatous diseases, something like Weger's granulomatosis or sarcoidosis, are more common causes for causing a septal perforation. Infective would not be mattering much, but every time we have this, the tuberculosis and all that, they will be infective actually, but the complications are all secondary to inflammation. That's why this has been put under inflammatory causes. Traumatic. This is the by far most common cause, that is finger picking, especially in children, because they don't know how deep or how fast or how violently they have to do finger picking, which actually is not supposed to, but because we don't have a control on them, we have finger picking as the most common cause in children, which will lead to first is bleeding. If the bleeding is still, bleeding is controlled and the crusting occurs, that is when the ulceration will start. If it is aggravated, that is when lead to a septal perforation. There is something also what is called as a substance abuse. Cocaine and people who use snuff, they are at the high risk of having a septal perforation. Surgical trauma, as in anyone with a over enthusiastic, they supposing in this case of septoplasty, what we do is we remove only we elevate only one side of the perichondrium. But supposing because of spur or because of previous fractures, supposing there is a tear at the level of the spur and the tear is on both sides, now this will act as a fistula, whereby this will lead to a formation of a septal perforation, which will be enlarging till the point at which there is a healthy mucosa and a healthy bone or cartilage underlying. Apart from all this, there is also what is called as accidental trauma. Accidental trauma would be because of some penetrating injury or a trauma which will lead to a hematoma and thereby leading to a septal perforation. Malignancy, again, multiple causes, but because we'll be bothered more about the malignancy, septal perforation will be taking a seat behind. Majority of the septal perforations, please remember, even in routine cases, especially neurosurgical cases like hypophyseectomy, transsphenoid pituitary axis approach, will have a septectomy, that is, we will be removing part of the septum. There will be a septal perforation, but that will be asymptomatic because we remove only the posterior one third of the septum there. But the size or the site can be anywhere. Depending on the size and the position, either the patient will be asymptomatic or he will be showing some symptoms. What determines whether he'll be having a symptom or not? Position. Because if at all the position of the perforation is in the anterior half or anterior one third, every time he breathes in, there is going to be a whistling sound, or the patient may identify a perforation by himself, that there will be a rent in the nose. But supposing if the perforation is way back, posterior half, majority of the times, unless the surgeon puts an endoscope, he will not even realize that there is a perforation. Depending on the size, supposing that size is determined as less than 1 centimeter, 1 to 2 centimeters, and more than 2 centimeters. So, depending on the size, we have different symptoms such as crusting, bleeding, block, dryness. Why would there be a crusting? Please remember, we are supposed to have a gel layer on the mucosal layer which will be moving around in a the nasal mucosa has got a gel layer which will be moving from anterior to posterior direction. Supposing we have a perforation, what will happen? The eddies or the air currents will be completely changed. Now this will lead to the drying up of the gel layer, which will lead to crusting. Crusting will in turn cause nasal block, or upon removal of the crusting, this will lead to bleeding. Again, this is a vicious cycle. That's why crusting, bleeding, block, and dryness. These are the symptoms of moderate to big size perforation. Then, what do we do? First and foremost, for especially cases of suspected tuberculosis or vaginous granulomatosis or malignancy, tissue biopsy is mandatory. That is why we need to make sure we are not dealing with any malignancy. Always take biopsy. Apart from this, what else do we need? We have to rule out syphilis, we have to rule out leprosy. All the traumatic causes will be definitely very obviously cleared by the history involved. But apart from that, in case when the history is inconclusive, a tissue diagnosis and lab investigations are mandatory. What is the medical treatment involved in this? If the patient is asymptomatic, please don't even bother doing anything for him. Supposing there is a symptomatic patient, that is, there is crusting and all, or there is too much of dryness. Routinely, steam inhalation is advised so that the crusting is minimized. That is, we are maintaining the humidification. Apart from that, what will be done is we'll also give 25% glycerin, sugar, glucose in glycerin. This will be helping in making the crust soft so that the nasal mucosa can do the rest of the job. Apart from that, alkaline saline nasal douching will also be advisable. But these are all medical treatment, as in just to avoid the dryness of the nasal mucosa. But definitive is surgical treatment. Please remember, surgical treatment is the best opted for less than 2 centimeters. Anything more than 2 centimeter size, what do we say, the perforation, the chances of recovery or perforation getting closed are really bad. They don't heal. So better leave it alone. What do we have? We have obturators, that is, they are something like small bobbin, that is what we see a meringotome. So we have either cyelastic bobbins or PVC, made up of PVC. So once we use it, we are covering that layer by either a graft or a flap. Graft is a free without any pedicle tissue, that is temporalis flap graft or a buccal mucosa graft. The flap is normally pedicled flap or a free flap. Free flap from the buccal mucosa or from the uh, temporalis fascia, whereas flaps, pedicled flaps are usually from the turbinate or the sphenopalatine artery flaps. So we covered the surgical treatment is by either a button or obturator, which is in turn covered by a graft for the maintaining the nasal mucosal continuity. This will end what are called as the diseases of the septum. Now, some of you have asked what is the weightage of the marks whenever we give our lectures. So please remember, septum as such can be asked as a 10 marks question. That will be usually anatomy and deviated nasal septum. Apart from that, septal hematoma or abscess can be asked as a 4 marks question or a 2 marks question. Leaford fracture 1, 2, 3 will be asked as a 2 marks question or a 4 marks question. Fracture nasal bones again is going to be a 2 marks question. Apart from all this, there's also everything about septum, that is blood supply, epistasis. Apart from that, septoplasty, everything can be asked as a 10 mark or a 4 marks question. Diagram, septum gross and blood supply of the septum are a stock question. You are supposed to remember it or able to draw the whole thing in less than 30 seconds. That is what it should be the goal. Apart from that, whether this is the only thing which is available in practical, septum will be helpful for your case. Every one of you will be having one, either a tonsil case or a septum case or a CSOM case. You'll be getting only two of it. So easily half of you will be having one septum case for sure. So this is what is the actual importance of our septum. Now that we have finished the midline, next class will be going on to the lateral wall followed by in the posterior wall. So I hope you people remember or go through your anatomy and physiology properly for the next class onwards. Thank you.